So we're going to talk about some of the core categories for degenerative spine pathology and the goals at the medical student level. So I'm thinking for basically a neurosurgical sub-intern, for someone who intends to go into neurosurgery, we want to work on an efficient diagnosis of some of the bread and butter pathologies, and then how to execute good upward communication to your intern, junior resident, senior resident, chief, and faculty. And we're going to categorize that into emergent, urgent, and routine or elective pathologies. And I'll also try to shed some light on what the attending neurosurgeon's thinking when you see a consult and we say, book them for a stat case or send them home, we'll follow up in clinic for a fusion or a decompression. And the other thing to keep in mind for a more general view, these are your patients too. They don't just belong to the neurosurgery attending or the senior residents. As soon as you have patient contact, that patient becomes yours, and they will rely on you. They may ask you, what does this mean? What should I do? So this really is your patient. So we're going to start with disc disease. And when you collect a history on this patient, they're primarily going to be complaining about extremity pain as opposed to back pain. When you examine them, they may have some focal motor weakness in a specific muscle group. If they have general weakness where both legs are weak in every muscle group, that may be more pain limited. And paresthesias, so pins and needles, loss of sensation, that's usually in a specific dermatome because it's a specific nerve that's compressed. In order to image this and diagnose it, we want to look at the nerves themselves. And in order to do that, that's best done with an MRI, because one of the first things you're taught in radiology 101 is an MRI gives you soft tissue, a CT and an X-ray give you bones. And that's why the MRI shows us compression or stenosis of the nerves. Sometimes you can't get that because different sorts of stimulators and pacemakers are becoming very popular and common in the population. So if you can't get an MRI, then you get a myelogram, which is basically an intradural injection of contrast dye and then a CT. But the CT won't give you the answer for this alone. The X-ray can be useful for operative plan because that shows us alignment and instability and helps us to determine fusion versus simple decompression. And again, these are different dermatomes. So you want to ask a patient when you collect a history, where is this extending into your leg? The front, back, side, medial aspect, and how far down is it going? All of that helps you to isolate which nerve is actually the trigger for this pain. So once you diagnose through history, exam, and imaging a disc problem or disc disease, the question is, what do you do about it? So isolated disc disease, so a herniated disc, about half the time over the course of 1 month, that will actually reabsorb. The pressure will get better and the symptoms will get better over the course of 1 month. So if a patient will often use the term sciatica radiculopathy, that basically is just referring to the electric pain from a nerve that's compressed. And that's going to get better over the course of a month. So unless there's a severe, dire deficit, we're actually not going to do anything. We're going to tell the patients, let's wait and see how this evolves. Steroids are very helpful because they decrease inflammation, edema, and that will make patients feel a lot better as a bridge to when this goes away on its own. NSAIDs are good as well. Injections can sometimes help to facilitate a diagnosis because if you do a selective nerve block where a pain management doctor puts a needle and anesthetizes a specific nerve, if the patient doesn't get better, well, then we know that nerve's not the problem. If they do get better, then that implicates a nerve as the problem, the trigger for the pain. Opioids are less helpful here because opioids, aside from the opioid epidemic and the risk of chronic opioid use, I don't like to use opioids for disc disease for what is often a temporary problem. Steroids are much more helpful. So when we do get to surgical management, so in the 50% of patients that have that herniated disc and the symptoms don't go away, the minimally invasive discectomy is the most common form of management. So what we're looking at here, this is an MRI. This is a sagittal view. It means we're looking in basically sideways into the body. And you can see, I know this pointer is not great, but hopefully you can see it a little bit. So this is the bone, right? The perfect square. And these are the discs in between the bones. And what you can see here is these are good, healthy discs. You see how this is hyper intense? It's a little bright here, and it's a little darker at the edges of the disc face. So that's a nice, healthy disc. It's hydrated. As you get lower, there's more stress. So disc disease is common lower in the lumbar spine. You can see they're darker. These are dehydrated discs that are starting to collapse. And as they collapse, sometimes disc material can herniate or bulge out into the cistern. When that happens, it pushes on nerve roots. That's the stenosis part. So that's a herniated disc causing stenosis. For a discectomy, in this case, some surgeons will do it open. Some surgeons will do it minimally invasively through a very small incision. What we do is we put a little tube down. That tube maintains our exposure, so fat and muscle don't herniate into the surgical field. And we drill off a little bit of the bone, access this disc material, and simply pull it out. That usually provides instant relief for the patient, because as soon as that disc material is gone, the nerve's not irritated, they feel better right away. They'll usually go home on the same day. They're able to walk right away. Because the incision's small, there's usually very minimal surgical pain. Patients can go back to work pretty early. There are restrictions on weightlifting, because if there is a hole in the annulus, which is basically the barrier that prevents the disc from bulging out, if the patient strains too much too soon, you can basically eject more disc material and have the same problem. It's important before this surgery to ask a patient, what's going on with your back pain? Because the leg pain, that radiculopathy pain shooting into the leg, that gets better. Back pain does not get better. Back pain is from arthritis, joint pain, bone pain. That doesn't get better by decompressing nerves. So this won't really have any impact on back pain. Sometimes the pain in the area is so severe, it radiates, and patients will say their back pain's better. But generally speaking, this is not a treatment for back pain. So here's the emergency, cauda equina. One common mistake is either an intern or a radiologist will say they are concerned for cauda equina because a scan looks bad. Cauda equina syndrome is a clinical diagnosis. Now here, this is a very impressive disc herniation. You can see that it's completely obliterating the spinal canal. So sure, this may be an elevated risk for cauda equina, but cauda equina is the symptomatic and deficit result of the compression. So you have saddle anesthesia, urinary retention, not urinary incontinence. The emergency department will often mislead you and confuse that. Bowel incontinence, and then progressive weakness, which could be focal or generalized. This is absolutely a clinical diagnosis. It's something you should be able to establish without imaging. And this is a surgical emergency. So once it's clinically suspected, the MRI becomes a hyperstat MRI. Then if you see this on the MRI, then you go straight to the OR for the decompression. The next type of spine pathology is what we call a spondy. And I want to just clarify the name, because there's a lot of different words that are used to describe this, but it's basically spondylolisthesis, and that is a slip of one of the vertebral bodies out over another. And there's 3 different grades based on how far forward you're slipped. That's not something you necessarily need to know now at your level, but as long as you understand what a spondy is, you're already a little bit ahead of the game. These patients will have a mix of nerve root pain and back pain. The slip itself causes tightness, and it also puts tension on the joints in the lumbar spine, which causes back pain. So these patients are going to have a mix, but you always want to ask them, what % back pain are we talking? What % leg pain are we talking? Because that impacts your plan for how to best treat their pain. On exam, it's really just like a herniated disc, where you might have focal motor weakness or generalized pain-limited weakness. The paresthesias or sensation issues could be variable. And to figure out what's going on with the nerves, it's the same thing. You want an MRI or a myelogram. The X-ray is helpful for operative planning, And that's where we like to get dynamic x-rays. A dynamic x-ray is also called a flexion extension x-ray, where the patient leans all the way forward and then they lean all the way back. And you shouldn't see the spondy getting bigger or smaller, but if you see it moving or shifting, that means they need a fusion, not just a discectomy, not just a decompression. And as far as the terms, so you have spondylolisthesis, spondy, a slip, pars defect, you may have heard of that in your anatomy classes. A pars defect promotes that slip and the spondy, and that creates the canal compromise or effacement or stenosis, where the nerves then become tight and compressed as they transit through the canal. So how do we manage a spondy? How is it different from just a micro discectomy? The first thing that I tell patients, I need to get their expectations in line with reality. And I tell them, your back pain will never disappear. If someone has knee pain and bad osteoarthritis in their knee, you can get a knee replacement. You can't get a spine replacement. We don't have the technology yet. So I'm sure someday we will. But because of that, because arthritis is usually diffuse, you can't just eliminate back pain. If you have one particular joint in the back that is really bad, you can fuse across it, and that will often help with the back pain. But I will tell my patients, you're going to have back pain for life. This is a palliative situation where we're just trying to make it better. Just because you see this does not mean the patient needs a surgery. So they deserve conservative management, physical therapy, injections. These patients are more typically given opioids because this is a chronic problem, and sometimes they will be on chronic opioids for this. But that comes with the whole debate over opioid abuse and how best to use them. But what I will tell patients, even though the back pain is never going to be gone, there are options to palliate it and to manage it a little better. And some of them are surgical. So the surgical management of a spondy, it often depends if it's fixed or mobile. Those x-rays can help us to figure that out. And first you need to accomplish a decompression. So you drill off the bones that are posterior to the canal, and that helps give the nerves room to breathe. Then a fusion stabilizes this mobile and potentially unstable slip. That fusion is what accomplishes a relief of back pain. The decompression is what gives you the relief of leg pain. That's the nerve pain or the radiculopathy. A fusion is a bigger operation. It means more blood loss, more post-op pain, more recovery time. That's a bigger physiologic stress on the body. So generally speaking, this isn't something that would be well advised in a 98-year-old patient. Additionally, a fusion changes the biomechanics of the spine. So it creates a bigger lever arm to the next joint. So if you do a fusion, the chances of following joint, the adjacent joint, deteriorating and degenerating at some point over the next 10 years or 2 years are pretty high. So just as you wouldn't want to do a big fusion operation in a 98-year-old, it's also something you don't really want to do in an 18-year-old, because if you fuse a joint in an 18-year-old spine, they will have adjacent level disease at some point in their life. This is what is more common. This is what I more typically see. So here we're looking at another sagittal T2 MRI. And just to go back, compare it to this. This is what I call single level pathology. We have one problem. It's right here. The rest of the spine, the hyper intense, the white here is cerebrospinal fluid. This is the spinal cord tapering off into the cauda equina and all the nerve roots coming off here. This is a pretty normal looking spine with this obvious exception right here. If you look at this, everything's messed up, right? You have all of these hyper intense bony changes. That's arthritis. That's basically spondylosis. You have discs that are collapsing onto themselves. You have end plates that are collapsing, and you can see the canal is pinched in at the disc bases because of herniated discs. So this is a patient that has probably very severe back pain. They probably have significant pain in their legs from nerve compression. And you could look at this MRI and you say, well, what the heck am I supposed to do? And if you get 10 spine surgeons, some orthopedic surgeons, some neurosurgeons, you're going to get 10 different ideas for what to do for a spine that looks like this. And unfortunately, with the obesity epidemic in this country, this is what most spines look like. One option, if it's a fairly healthy patient, is you can do a huge operation and realign and fuse and decompress everything. That's the most definitive treatment. Sometimes that's the right way to go. Other times, the best thing to do for the patient is the smallest, least invasive footprint. So what's tricky for this multi-level disease, these patients are, like I said, they're going to have the back pain, radicular pain, claudication, which we're going to talk about in a second. And you really need to rely on your exam and your history now. Figure out of all of these problems in the spine, which one is the actual trigger for their pain or their deficit. And if you can just fix that, you can make the patient pretty happy without giving them an enormous operation. So again, for this problem, you want to look at the nerves, look at the MRI, get a myelogram if they can't get the MRI. And the X-ray helps to tell you what's unstable here. Are the bones moving on top of each other? Because if they are, then you really need a fusion. You can't do a decompression at an unstable level because you take instability and you're just making it worse by drilling off bone. But if you can get a pain management doctor to put a needle around a specific nerve, numb it up, and the patient says they're happy, then you decompress one nerve. And that just means drilling the bone and taking the disc material around the one nerve. And that may give you a good result. So here we're talking about claudication. So you guys probably covered this a few times in different med school modules. Claudication, there's two kinds, neurogenic and vascular. And unfortunately, they have very, very similar symptoms. And that can be a non-dermatomal, non-specific burning in the legs, can be unilateral or bilateral, that is accompanied by weakness. And these symptoms, these problems, get worse with walking and exertion. So this is kind of a busy slide here, but just to give you a little bit of clarity, for neurogenic claudication, sometimes it's positional. If you lean forward, the neuroforamina actually open up a little bit more. And if you stretch backward, they tighten up and the symptoms get worse. So one classic example is if somebody has neurogenic claudication, they can bike very well. If it's a stationary bike, they can exert themselves and do well, no problem. If it's vascular, that's a blood supply issue. It doesn't matter what position you're in. As long as you're exerting yourself, you're going to have the symptoms. And that's, aside from all of these other different characteristics to try to memorize for standardized tests, which one causes which, what matters the most when you're examining a real patient is, do they get positional relief? If the answer is yes, you're thinking neurogenic, and if it's no, you're thinking vascular. And as future neurosurgeons, your ability in the clinic to determine if a patient has normal or diminished pulses in their lower extremities, you're going to have to rely on someone else for that, because that's not something that's going to be in your skill set. But again, there will be pulse and blood supply and blood flow issues in the lower extremities, but that's not going to be your responsibility to figure that out as a neurosurgeon. So we talked about this a little bit. You want to isolate the symptomatic pathology. That's sort of the core tenet of all of spine disease. Find out what's causing the symptoms. If you have an MRI with a herniated disc and no symptoms, you don't inherently need to do something about that. You need to draw a bridge for the patient and for yourself between the abnormality on the MRI and the patient's symptoms or deficits. If you can build a strong bridge there, that means you can help them with surgery. If you can't isolate a connection there, surgery is not going to accomplish anything. And that really is the core tenet of all of spine surgery, but it's especially important when you have a highly abnormal spine like this one, where there's one of 7 different triggers that could be causing the pain. So what we could do here, again, it varies from a simple decompression, where we go in a minimally invasive fashion, open up around one nerve, or a substantial fusion. And it really depends on our ability to isolate the pathology. So again, this is important because you will be talking to these patients. They'll be asking you, I had a neighbor who had spine surgery and they were never the same again. Or I had a friend who had this surgery and they did great. Their pain was gone and they went home 45 minutes after surgery. Your patients will be basing what their decision should be on anecdotes. So it's very important to provide them realistic expectations of what will and will not happen. Generally speaking, leg pain, the radicular pain, it usually gets better. Back pain usually does not. The neurosurgical and the spine surgery literature, there's lots of new tricks that are evolving, things that we're trying to do with helping back pain. And we do help back pain, but it's just more of a roll of the dice. It's less reliable than treating nerve pain. And elective spine surgery, one thing that's, I always draw this comparison for my patients. I have a busy brain tumor practice. And if a patient has a malignant brain tumor, that needs to come out, whether the patient wants it out or not. Obviously, they need to consent to the operation. But if they're told you need this out if you want to continue in your fight against brain cancer. However, with spine surgery, it's a little different. The patient should play a role in the decision-making on whether or not to have surgery. Because unless they're going paralyzed and it's a surgical emergency, if we're making decisions based on pain and subtle pain-limited motor deficits, then we really need to have the patient play a part in that and understand these are the risks, these are the chances things will get better. Maybe surgery is not for you, or maybe it is. Different patients are willing to accept a 20% chance at symptomatic improvement. Other patients want a 90% chance of their pain getting better. So they need to be part of that decision. And obviously with physician approval, because you shouldn't be doing a shot in the dark operation for a patient that's desperate in pain when you don't think it's going to help. It is tough to say no to a patient. In my practice, the most upset patients are patients with bad spine pain that I say, I'm sorry, I'm not recommending surgery. Patients get upset, angry with you for that, but you have to do the right thing. So do not allow yourself to be convinced to do a surgery that you don't think will help someone. And again, the takeaway here for what we covered in the lumbar spine, the emergency is Cauda-Equina syndrome. Just a couple cartoons that I think are visually helpful. So we showed you a sagittal MRI. This is obviously a cartoon, but it's in the axial plane. So what you have here, this is ventral, this is dorsal. So this is the back of the patient. To look at some of the normal anatomy here, you have a spinous process. This is a transverse process. In this particular cut, you cannot see the pedicle, but a pedicle would be coming down like this, leading into the vertebral body. The reason you can't see the pedicle at this cut is because we're at the level of the foramen, which is where the nerve root comes out. This is the spinal canal, and this is the nerve root exiting. This is a normal, happy, non-compressed nerve root, and this is the compression you get when a herniated disc comes out and pushes into the foramen. That causes radiculopathy. Here is basically the surgical intervention. So a laminectomy involves removal of the spinous process and removal of the lamina. The lamina is the bone that transitions off laterally from the spinous process and covers the thecal sac or the dura. So when you drill that off and carefully remove that, it provides this decompression and gives the nerve roots room to breathe. Sometimes you can also take the disc fragment, so you can reach around the nerve root and take this disc fragment so you get a 360-degree clean out. Other times, maybe it's too stuck, it's difficult to access, you only do a 180-degree clean out, basically like a convertible, but that still gives the nerve room. So with spine surgery, with the exception of scoliosis, which is a different entity somewhat, it's all about neural element decompression. If you decompress the neural elements, patients will feel better. And that's what we're visually showing here. This is the same picture that I showed you before, just a slightly different view. So this is now a coronal view. This is what you see in the OR. You have the wound open and you're looking straight down into a prone patient that's face down. These are the spinous processes, and this is the end product of a laminectomy surgery, where the thecal sac is decompressed. This is the same view. So this here This is the same view. This is what we're removing, the spinous process and the lamina. I would argue in this case, we need to remove a little more. So this edging into the joint, so these are the joints where the different levels are connected. We would need to get a little closer out towards the joint to actually decompress these nerve roots. So this would be sort of an inadequate laminectomy, but at least it's a good visual. All right. I see something just popped up that I saw in the chat. Does decompressive surgery lead to instability? And that is the million-dollar question. The short answer is yes. We have evolved the structure of our spine for a reason. And if you start drilling off bones and taking ligament, you develop instability. The question is, how much can you take in what type of patient, and what levels can you take without creating instability? So the more you take, the more likely you are to need a fusion. Those X-rays that I talked about, they're very important because they help you to see is there pre-existing instability, which means you definitely need a fusion. Generally speaking, when you start to decompress into the joint, so let's look at this joint here. So I said we need to get more here. The further you get into the joint, the more that you need to consider a fusion because joints create stability. I see another one that says, how do you create the spine cool during procedures? So the temperature of the spine exists at the normal body temperature. So there's nothing that we do during surgery to heat it up beyond what would be a normal tolerable homeostasis. So temperature management during the surgery is something that's not a concern. Here's another example. This would be a 2-level laminectomy where the lamina are removed, and you can see that basically the canal, the tunnel for these nerves is wide open. All surgery has risks. So just to cover some of the quick risks when patients may ask you for spine surgery, the number one risk that we're always thinking about is durotomy. So the fecal sac basically has the consistency of a water balloon, although the dura is a little bit more friable than the wall of a water balloon. But the lumbar cistern, these nerves are swimming around like spaghetti, and they're encased in cerebrospinal fluid. If, for whatever reason, a piece of bone or a sharp instrument pierces that fecal sac, you see cerebrospinal fluid rush out. And that's when you'll usually hear the surgeon curse. So that creates a few problems. One, you can actually see nerve roots herniate out through that defect in the fecal sac, and that can damage nerve roots and cause weakness. The other thing it can cause is a permanent leak. So when that hole is created, we need to sew it shut, and that needs to be watertight. If it's not watertight, after the surgery, it will leak out through this fecal sac, and then it will leak out into all of these tissues that we opened up to access the spine. And cerebrospinal fluid prevents wound healing. So then this wound is going to break down. Whenever I hear a patient call the office and say, I have this clear fluid coming through my incision, that's an automatic straight to the emergency department because I know we need to open them up and repair the leak again. Once CSF creates a fistula or a pathway to the outside world, that's a problem with wound healing. It's a risk for meningitis. In the lumbar spine, it creates a vacuum. So you lose upward pressure on the brain because it's all coming out through the bottom of the lumbar spine. So you can develop subdural hematomas. This is exceedingly rare, but a patient can even herniate and die if they're losing enough CSF from below. So that's the one risk that concerns us with spine surgery. Durotomies occur depending on the type of surgery you're doing, the type of practice, and the type of surgeon you are. Durotomies should be anywhere between 1% and 10% of your cases. Usually when you have a durotomy, you repair it in the OR. That's the end of it. Doesn't create any problems. But again, about 10% of the time when you have a durotomy, it creates a problem. So overall, we're looking at about 1% to 2% of spine cases where we have an enduring problem from a durotomy. The thing that upsets me the most is when a patient gets no relief after surgery. I do a surgery on them and they come to see me in clinic 2 weeks later, 3 months later, and they say, I wish I didn't have surgery. I don't feel any better. That bothers me. And I know I didn't help that person. And so why does that happen? One, it could be poor patient selection. I picked the wrong target. It's not that we did a wrong level surgery. It's that the level that we targeted that we thought was causing the symptoms wasn't causing it, because I decompressed that level and their symptoms didn't get better. An inadequate decompression can be a reason that a patient has ongoing symptoms, or sometimes it is that you picked the right level, you did a good decompression, but the nerves are basically forever irritable and damaged, and the symptoms just won't go away. And that's where we rely on pain management, different medications like Neurontin to try to do something. But any problem, no matter how black and white, cut and dried, you're always still looking at an 80 to a 90% chance of relief. There's always going to be a chance that you do the surgery and it just doesn't help. Another issue is wound breakdown. That's pretty straightforward. Anytime you make an incision in the body, a wound could get infected or break down. And we spoke a little bit already about adjacent level disease, where you create a bigger lever arm for the adjacent level when you fuse 2 levels together. It's even bigger when you fuse 3 levels together. So adjacent level disease is a breakdown. What is a breakdown? I didn't really explain that before. If there's a lot of stress on a particular level in the spine, whether it's from obesity or multiple fused levels above or below, that stress causes the joints to hypertrophy and enlarge, and it causes the disc to deteriorate and collapse under greater forces. When those things happen, you get a mass, either an enlarging joint or a herniated disc, and that mass goes into the canal and the neuroforamen and compresses nerves. That's the stenosis and the compression. And that's what causes symptoms. So when we talk about adjacent level breakdown or adjacent level disease or stenosis, that's what we're referring to. All right, now we're going to shift to the cervical spine. It is basically the perfect analog to the lumbar spine. And when someone has disc disease here, now what we're looking at, this is a axial, so we're looking straight into the canal. Imagine the spinal cord going into your screen and coming out of it. This is a T2, which makes CSF bright, and it makes some other structures dark. So this is the spinal cord. The spinal cord should be a perfect oval or a perfect circle. In this case, it looks like a kidney bean because it's being compressed by a herniated disc. Even more important than the spinal cord itself, well, not more important, but in this case, more important, is that there's a nerve coming off of the spinal cord, going out of the foramen, and it's being compressed and pinched by this disc. So just like with lumbar disease, you get focal pain, in this case, the arm, or weakness. You may get difficulty with fine motor tasks because now there are no fine motor tasks with the feet, but if nerves are compressed, patients will say, I struggle with buttons, I struggle with writing. And you may or may not have some neck pain as well. So on exam, you're going to get focal weakness, dermatomal paresthesias, hand dexterity could be a problem, but you really shouldn't have leg weakness or difficulty walking. That's a spinal cord problem. That's myelopathy. Radiculopathy means you have a nerve problem, a peripheral nerve root problem. So on imaging, same thing. MRI is the best way to do it. X-rays help for operative planning to look for instability. So how do we manage this? The conservative options are physical therapy, traction, because if people do these physical therapy sessions where they actually put traction under their jaw and distract here. And what that does is open up the neuroforamina. Selective nerve blocks, just like with the lumbar spine, are helpful to diagnose the exact area that's a problem. If the problem persists and conservative management fails, or if there's a profound neurological deficit that we really need to reverse, then we consider surgery. For the cervical spine, the big question is always front or back. So I'm going to give you some big generalizations here, and as you guys move along in your neurosurgical training, you'll learn some of the more specific reasons to consider front versus back. But generally speaking, an anterior approach, which is an ACDF, anterior cervical discectomy and fusion. So that anterior approach is generally better for more limited pathology. You're not going to do 5 levels from the front. It's too extensive. It's too much of a reach. and it's too much stress on the midline neck structures like the esophagus. So more limited pathology and isolated disc disease, because think of where the vector of compression is coming from. Anterior, the disc is anterior to the spinal cord. So you remove the disc in an anterior fashion. Arthroplasty, so you can actually put in an artificial disc between adjacent levels of bone. That's better for younger patients with isolated pathology and good alignment. A patient with bad alignment, you're better off just fusing it. Posterior, so the posterior approach, that's a bigger incision, more pain, more recovery. That's better when you have to do a more comprehensive operation, when there's multiple levels of pathology. And oftentimes that's where you're talking about a fusion as well. But you can still do an isolated decompression. So now we're going to get to myelopathy. These are spinal cord problems as opposed to cervical nerve root problems. You can still have all the signs of radiculopathy because you can still have compression and stretch on the nerve roots. But what we're adding in, now we're talking leg weakness. Now we're talking difficulty walking, difficulty with balance, because the spinal cord and the long tracts that are going down to the legs are now affected. So this is where this goes to your neurology rotations. You're going to see hyperreflexia, clonus, Hoffman's sign. And in this case, I don't know if the resolution is good enough on your monitors, but there's cord signal change. This hyperintensity in the cord is edema, fluid, and water inside the cord that reflects damage to the spinal cord. So once a patient has myelopathy, there's no room for conservative measures. The only way to fix myelopathy is with a surgical decompression. You can do that with an anterior approach. You can do that with a posterior approach. In this case, we're looking at a T2 MRI, sagittal view. We're looking at the spinal cord dropping down here. And you can see, look at all this space, this hyperintense CSF space here, and a complete loss of space for really 4 contiguous levels. So this is a patient, could you go from the front? Yes, but the more extensive the work you need to do, the more likely it is that you really need to consider a posterior approach. Also, if there's a posterior vector of compression, then you definitely need a posterior approach. So this is a patient who had a posterior decompression. You can see these are the spinous processes. You can see they're gone here. So there is just a void of all the bone, what we call the posterior elements. They're all removed. And you can see that the spinal canal is now wide open. So what are the risks of cervical surgery? Just like we talked with lumbar, there's always a risk of adjacent level disease, whether you're anterior or posterior. Wound breakdown and infection is a much bigger problem posterior than anterior, because anterior you have a very small incision on very fluctuant skin. It's not common to have a problem there. You can have instability if you do a posterior decompression without a fusion, and some very rare but very severe complications. You can have a spinal cord injury, which is obviously devastating, and you can have a vertebral artery injury because the vertebral artery is coursing through the lateral aspect of the cervical vertebrae, and that can be injured and that can cause a stroke. And you can also get worsening weakness even if you give a perfect surgery, but there's just a little too much manipulation of the nerve roots or the spinal cord beyond what they can tolerate. So those are the core risks to discuss with patients. Now, one last thing, it wouldn't be right if we went through a spine lecture that covered emergencies if we didn't get through this. This is becoming an epidemic. It's becoming progressively common. No matter what form of neurosurgery you go into, and no matter where your practice is, this is something you will see and you will be accountable for when you're on call. And that's an epidural abscess. It could be from IV drug abuse. It could be from poorly controlled diabetes leading to an immunocompromised state, HIV, cancer. Those are all risk factors. And all of those things are why we're seeing more of it now than we used to. The presentation is going to be very similar to patients with degenerative spine conditions. You get back pain, neck pain. You can have radiculopathy. The big difference, you may see a fever, although not necessarily. So on exam, you'll actually have palpable tenderness, whereas with degenerative disease, you won't have that. But for the most part, this isn't something that you can really distinguish from exam alone. You can get some risk factors from clinical history though, but it's something you really need to find on the MRI. In this case, we have a T2 MRI. So you can see up here in the cervical spine, again, there's space. This level is a little tight from degenerative disease, but it's completely fine. And you can see the hypointense, the dark spinal cord running down into the upper thoracic spine, and it's being pushed anteriorly by this collection here, which is the abscess. So some of the radiology terms you'll see are enhancing, because the abscess will enhance when you give IV contrast. Epidural, this is in the epidural space. Abscesses are almost always epidural, so it pushes, you don't enter the dura for these cases. Phlegmon, that just refers to the abscess itself. Mass effect, so it's pushing on the cord, it's exerting mass effect. How do we manage these? So this is a multidisciplinary approach. It's not just neurosurgery. We need interventional radiology, internal medicine, and ID as well. So the principles of management, one, we want to isolate the infectious organism, and that can be done via open surgery if necessary. It may have already been done through blood cultures, or it can be with IR doing an aspiration. Once it is isolated, then you want to initiate the appropriate antibiotics after the bug is confirmed. You need to manage pain, and you need some sort of follow-up to confirm resolution of this. So again, these are the two ways that you get problems. One is direct mass effect and pressure on the neural elements. Two is irritation of the blood vessels and the venous plexus in the epidural space. That irritation can cause a thrombophlebitis, which can cause blood clots, which can cause infarcts of the spinal cord. That in turn can cause some pretty devastating problems. So these are the indications for surgery. This is something you will be pimped on at some point during PGY 1 or 2 of your neurosurgery residency. I think I was asked this probably 7 times over the course of my residency. So these are the indications for surgical decompression in the setting of epidural abscess. One is a progressive neurological deficit. If you have that, the abscess needs to come out. That's an emergency. Doesn't matter where it is, what it looks like. If you have a progressive deficit, that's a surgical indication. 2 is if the abscess is located in the cervical or thoracic region. That's an urgency, but not an emergency, because that involves the spinal cord, and that gives you that thrombophlebitis risk. That's less of a risk in the lumbar spine when you're not dealing with the spinal cord. The next one is antibiotic failure. So if this is basically progressed through multiple different antibiotic regimens, then you need a direct mechanical washout as opposed to indirectly relying on antibiotics. So a lumbar epidural abscess without a neurological deficit, that's what's managed conservatively with antibiotics. Now, you will see indication or a few isolated instances where a cervical or thoracic epidural abscess does not get a surgery. And that's because it's just so unimpressive. Maybe it's one small little linear area of enhancement, and sometimes the surgeon will elect to sit on that. But generally speaking, it's anything that's adjacent to the spinal cord is safer to take out. All right, so now for the last 15 or so minutes, we can go through some cases. Don't hesitate to, you can either talk or type your answers, however you guys feel most comfortable doing it. But for the first case, we've got a 65-year-old female presenting with long-standing lower back pain. And that's basically, that's a very common, you'll see this in your clinic endlessly. So what are some questions we want to ask, studies we want to get? What do you guys want to do? I can't see if anyone's typing. All right, Mike, I'm picking on you.
I mean, general, onset provocation, radiation type stuff. Where is it located? Is it going down an extremity or more just localized to the back?
Mm-hmm. So there is back pain, but the pain is worse in the legs. And I see a question, is the pain better when standing for a long time? So the pain usually gets worse with standing. And here, I'm going to go to, so it's in both extremities. They've had PT, they've had epidural injections, both have failed. and they're full strength on exam. So this is an X-ray that their primary care doctor obtained. So it's a lateral X-ray, and we're looking at the sacrum here. This is L5, and this is L4. I see someone said spondy. That's perfect. So you can see the slip here. And what that slip creates, you see this is a foramen, right? We can't see the nerves because it's an X-ray, but this is a normal foramen. And this foramen is potentially pinched off by this slip. And that's what might be causing the leg pain. So we have this X-ray. Is there anything else we want? I see MRI. Good. So here's the MRI. We're looking at the sagittal here. So this is a T2 sagittal. We're looking at the same slip. And what this slip has caused is severe central canal stenosis. And you can't see it without really either strolling side to side on the sagittal or using axials, but there's bilateral neuroforaminal stenosis as well. So what options do we have for this patient? I see surgery. That's good. I'm a surgeon. I like surgery. The first thing I'm going to tell them, nobody's going to go paralyzed from this problem if we don't operate. So it's not absolutely essential that we do surgery. They don't have weakness. So they don't have to have anything done, especially if there's no deficit. So the first thing I'm going to do is I'm going to ask them, how bad is your pain? Do you want to do something about it? If they're in a neurosurgeon's office and they've had PT and they've failed injections, the answer is invariably going to be yes, they want to do something about it. But you always need to ask, because sometimes patients will be misinformed and they think they're there because something is wrong and they need surgery whether they want it or not. So anyway, this patient, I see somebody said surgery and fusion for the spondy, question mark. The answer to that is yes. So this patient needs a fusion because of that spondy. So what we have here, this is a L4-5 fusion. So we put in pedicle screws. I'm going to show you that in just a second. And this is a interbody fusion. So to help reduce the spondy and open up the foramen, we put a spacer in there. We take out the disc and put in a spacer. And that distracts the joints open and gives the nerves more room. But it also helps to lock these slipped bones in place. So this gives them a chance of helping with the back pain, but very definitively helps with the leg pain. Here's a little anatomy to correlate that fusion. So we're looking at an AP X-ray here. Now in med school, you'd probably say this is an abdominal X-ray. As a neurosurgeon, I don't know what any of the abdominal structures look like, and all I can see here is a spine. So in the midline here, this corresponds to the yellow. These are the spinous processes. The most important thing are the red. These are the pedicles. So the pedicles are a little hard to the untrained eye to figure out what they are on an X-ray, but they're these ovals that are sort of ill-defined. And the pedicles, to look at the cartoon, so this is kind of like a axial. This is the pedicle. So this is the surface here, and this is the anterior part of the patient. So if you're doing a fusion, you put in a screw that goes from here through the pedicle and into the vertebral body. So this is what fuses together two adjacent levels of the spine. So pedicle screws above, pedicle screws below, and the screws are locked in by rods. That's what a fusion is. So on the X-ray, which we rely on during surgery, that's how we know that we're actually going into the right space. Is we look at the X-ray, we define these pedicles, and that's where the screw goes. So to correlate that with the cartoon, I already showed you on this one. This is a lateral view or a sagittal view. The pedicle screw goes in like this, through the pedicle into the vertebral body. This is the view you see in the OR, which corresponds to this, because this is the back of the patient, which is face down. So the entrance point into the pedicle is somewhere right around here. And that's what goes in there, through there, and into the vertebral body. So that's a pedicle screw, that's a fusion. Next case. Now we have a 42-year-old male, 2-month history of electric pain going from his neck and radiating into his shoulder and his arm. This patient has not had PT. They have not had any injections, and they have biceps weakness, 3 out of 5 on the right. What do we think? What do we want to do? I see injections. So injections are always a great start, but here's my concern. Injections, PT, all good, but my concern is weakness. So if it was isolated pain, I'd want to do everything conservative first. However, with a concern for weakness, that's a problem. So here's this person's MRI. We see pretty good alignment, and we see a herniated disc at C4-5. And that disc is pushing into the spinal cord. Excuse me for 1 second. I got the emergency department calling me, asking me about something. All right. So with this herniated disc, this is causing a C5 palsy, C5 radic. Excuse me for 1 second. I apologize, guys. Hello? Hey, I just got your text. I'm sorry. I was actually doing a presentation, a talk right now. But that looks like, so that's a trauma, I assume? And then just hit the ground. Regardless, they'll need a blood pressure cap of 140, and they'll need to be sent up north. Yeah. Sure, I would. Yeah, collar's fine until it's ruled out. Yeah, absolutely. All right, thank you. Perfect. Thanks. Bye-bye. Sorry about that. I always get one of those every time I'm giving a talk. So with the herniated disc in the cervical spine, first we ask, is the spinal cord involved? Is it just nerve roots? Based on the exam here, with a focal motor weakness, biceps in this case, this is a nerve root, not a spinal cord problem. When there is a significant motor deficit, that's what makes me blow past conservative management and say, let's just get this dealt with, because I don't want to run the risk of the motor deficit being permanent. So this patient would go right to surgery, not emergently, but I wouldn't wait 2 months for physical therapy. So I'd book them for surgery in the next couple weeks. This is what the surgery looks like. So we're looking at a lateral X-ray where we have screws going into the vertebral body above and below. The disc came out, and there's always some sort of material that goes in here to facilitate a fusion across the vertebral bodies. And then there is a plate, which is analogous to a rod, that connects these screws to create stability and a fusion across the level. The reason it's almost always a fusion when you go in from the front is that you need to put something in there. And unless you have a perfect artificial disc that creates motion, you need to do a fusion. This was done through an anterior approach. So this is anterior, this is posterior. And when you have single level pathology, it's best to come in anteriorly if it's an anterior problem. In this case, it's an anterior disc. So that would be an anterior approach. Now, one thing, you guys have probably been exposed to this, but I just want to reinforce it because it's part of the language that will be spoken very frequently from day one that you guys hit the floors. So I said here, 3 out of 5 right biceps weakness. So this is the strength scale, and it's extremely important. There's certain things that you don't really need to understand for a while, but this is something, it's best if you get it right away. So 5 is full strength. 4 means there is meaningful strength, but it's asymmetric with the other side. There is noticeable weakness. 3 means the patient can lift their arm, their leg, whatever the muscle group is. So it's anti-gravity, but they fail to provide any resistance. They break instantly. 2 means they can move it. They can move this joint in the plane that is perpendicular to gravity, but it cannot be lifted against gravity. 1 means all you're looking at is a muscle flicker, almost nothing. And 0 means no movement whatsoever. So 3 out of 5 weakness is substantial, meaningful weakness that is something somebody should not have to deal with for life. So we would do a surgery to intervene sooner rather than later. 4 out of 5 weakness, depending on the level of which it distresses the patient, that's something you can occasionally sit on. And last but not least, this is not something you need to memorize right away, but the sooner you become fluent with it, the better. And throughout your careers, this is something you're going to periodically check on. But these are the dermatomes. So when a patient has radiculopathy and they have electrical pain shooting from their neck, their back into somewhere else, this is very helpful in figuring out what nerve is the problem, what nerve do we need to decompress. There is anatomic variation from patient to patient. So not every patient reads the textbook on this, but it still can be very helpful in determining what surgery you're going to do. So it's most important for the arms and the legs. So this can differentiate if there's 5 levels that are bad, but a patient says, well, I really only have pain in my butt and it shoots down the back of my leg and the side of my foot. That's an S1 radic. So then you know L5-S1 is the disc that's causing the problem. So if they have other bad discs, you don't have to do a comprehensive surgery on all of them. So this chart is something that is so important to consistently go back to. So I see a question here, which fingers specifically are involved to localize dermatomal distribution? So the patient that I just showed you had a C4-5 ACDF, and they had biceps weakness, which that's primarily the C5 nerve root. So where do you think, based on this distribution, where do you guys think their pain would be? Or I'll make it a little easier. Which color or polka dot pattern do you think their pain would be? So I would say, and again, it's not 100% because you could get C6, but for C4-5, I would more expect C5 because you usually get the exiting nerve root in the cervical spine from a herniated disc. So that would be the C5 region. So that would be pain out over the shoulder, the clavicle, the bicep, and the forearm. So it may not actually go into the hands. However, a big enough disc at C5 could still irritate C6, C7, C8. So that's why it's not perfect. You can still get pain in other regions from a herniated disc at one level. But if you had true single nerve root pathology, this is what it should generally follow. All right, so that's all I have. Are there any questions at the end now? And you guys are always more than welcome to reach out if you have questions, a specific case you're curious about. I'm always available.
Thanks so much, Dr. Johnson. That was awesome.
Yeah, absolutely.
One quick question I had. So I'm sure this is, really hard to kind of judge and tell when, the pain started exactly, but is there a time when, you would consider if the pain has been there for, let's say 6 months, that the nerve might not be salvageable in terms of reducing the pain?
There is no fixed cutoff. So people can have longstanding pain from compression and they can feel a lot better after a good surgery. Generally speaking, so claudication, if someone's had longstanding claudication, that can still get better after a long time. If someone's had longstanding radiculopathy, like 3 years, I'm usually a little more concerned that that's not going to get better. So there is some nuance to that. Other things, if somebody's had 5 spine surgeries and I'm going to be the 6th, it doesn't take a medical background to realize number 6 probably isn't going to get you somewhere special that 1 through 5 did. So the longer they've had the pain, the more, and I'll be happy to share my email, the longer they've had the pain, the longer they've had a deficit, the more concerned I am that it's not going to get better. So you mentioned pain. The corollary to that are motor deficits. So a motor deficit that has been there for more than 6 months, I'm very concerned that that's not coming back. If there is, the other thing I'll tell patients, if I operate for myelopathy, the duration of their symptoms is usually the duration of how long it takes for things to get better. So pain can get better instantly, but if you've been myelopathic with balance issues for 4 months, it's usually going to take about 4 months to turn the clock back and rehab through it and get better.
Great, thank you for that.
Yeah, absolutely. Thank you guys for having me. I'll just type in my email. I'll put in my Rutgers email.
Perfect.
And you are all more than welcome to reach out. But thank you again for having me.
Absolutely. Thank you for spending your Saturday with us.
All right. You guys have a good one.
Take care.
Bye-bye. Hello? Yes, what can I do for you?
Okay, and I see Dr. DeCypher is logged on here. So Dr. DeCypher, I think you've been made a co-host, so you should be able to share your video and screen. Awesome.
Okay, will do.
All right.
Let me just share my screen.
Perfect. And I'll give you a brief intro. So Dr. DeCypher is joining us from Northwestern. He's a assistant professor of neurosurgery there and a pediatric neurosurgeon at the Lurie Children's Hospital. He has earned his MD and PhD from the University of Tennessee Health Science Center, where he studied, I believe it was motor circuits and dopamine neurotransmission. Awesome. He then completed his residency at UTHSC and the Semmes-Murphy Neuro and Spine Institute there. Did a minimally invasive neurosurgery fellowship out in Australia, and then completed his fellowship training in pediatrics at St. Jude's Children's Hospital before coming to Northwestern. In addition to his clinical responsibilities, Dr. DeCypher is also a productive researcher and actually serves as the director of translational research and clinical trials there. So, awesome background, and we're really excited to have you here with us today.
Thanks, Mike. Can you guys see my screen okay?
Yes, sir.
Okay. So you guys asked me to discuss basic endoscopic techniques and sort of principles in pediatrics. So I thought I'd keep it at sort of like the medical student level or the junior resident level, and discuss things that I expect or that we as pediatric neurosurgeons expect you guys to know, or would be awesome if you did. If you're on a rotation and we ask you questions and you know these things, you're going to look like a star. So that's sort of what the level I wanted to keep it at, and with a focus on peds, because we do a decent amount of endoscopy in peds. However, it's a bit different than some of the endoscopy you see in adults, and I'll talk a bit about that. So in general, let's just start with the difference between microscopy and endoscopy, because we use both in neurosurgery. And so if you've ever seen neurosurgery or been around neurosurgery, you know that microscopy is, we use it on virtually every case in neurosurgery. It's well established. We've been doing it for 30 plus years now. It's part of your training. It's part of what we do. And it provides a high resolution stereoscopic view. However, in narrow and deep surgical corridors and approaches, you lose a lot of light actually. And especially in a minimally invasive surgical scenario, that can be an issue. And that's where the endoscope and a lot of open surgeries comes into play and becomes a nice adjunct or even a primary tool for surgery. And as you know, we're getting more minimally invasive all the time when it comes to surgical approaches in neurosurgery. So in the setting of the microscope, the surgeon actually works within the light beam, which can also further diminish the intensity and the view in the surgical field, meaning that your hands are in the surgical view in the microscope. And with microscopy, you can only visualize the surgical structures when they're located in direct view of the lens, or they're directly in front of the lens. However, with endoscopy, the endoscope provides a panoramic view, and this can be a major advantage in narrow and deep surgical corridors, as you can see on the diagram on the right side of the screen. If I'm looking in the ventricle, I'm a lot closer to the structures of interest, and I can directly visualize them. I can bring the light source to the structure that I'm operating on. In addition, endoscopes are made with angled optics, which allow me to look around a corner or behind structures. As you can see, this is a example of a 30-degree endoscope, where I can look around corners or behind the surgical field in a way. And this brings our eyes close to the target with great illumination in a deep field. But what are the limitations? Why aren't we using endoscopes for everything? Well, clearly, we're limited by technology. And as compared to a microscope, an endoscope does not really provide a true 3D view. It does give you a bit of a pseudo 3D view based on sort of what we call motion parallax. But the microscope has better resolution due to larger lens diameter and direct visualization through the lenses. And in this scenario, the surgeon's retina becomes the sensor, which is much better than video cameras that are used for endoscopy. And even at modern, 1080p, 2 million pixel images, the image quality is still inferior as compared to the human eye in a microscope. However, they're getting better all the time, and we use endoscopy virtually every day in a lot of surgical scenarios. So what does an endoscope look like? So this is what you can see on the left side of the screen, grossly what most endoscopes look like today. The endoscope in this picture has this kind of bit at the bottom here with the green little sort of indicator. This is where the light source goes. So when you plug in an endoscope and you're using it in the operating room, you're going to have a camera and a light source. They're separate. So the light source plugs into this area of the endoscope here, and then the camera plugs into the back portion of the endoscope here. And then the tip of the endoscope on the right side, you can see typically has a camera or the area that has the light source and camera combined into one. And then they have some combination of working ports. This is usually the working channel of the endoscope. This is a intake and exit ports for irrigation most commonly. And then the working channel provides introduction to a variety of tools, whether they be graspers or cautery or even other cameras in some scenarios. But that's the basics of the way these endoscopes work. Now that's an example of a rigid endoscope. Okay, when we say rigid and flexible endoscopy, right now we've just been talking about rigid endoscopy. And so here are some examples of endoscope holders and kind of operative configurations. You can see here, this is the light source going into the endoscope. Here is the camera here connected to the optics portion of the endoscope. And then this thing over here that's covered with these plastic, that's an endoscope holder. Some surgeons like to use an endoscope holder that actually holds the endoscope in a fixed position, and you can move it after it's attached to the bed typically. Or you could have a second assistant, which may be a resident or a student or another surgeon, holding the endoscope for you while the other surgeon works with a variety of tools. And you can see here on the other photo on the right side, this is a tool being inserted through the working channel of the endoscope. And here the surgeon's using it to take a biopsy or poke a hole in something. And the endoscope holder is holding the endoscope in place. And so, as I mentioned briefly before, there's lots of different types of endoscopes, both rigid and flexible. For rigid endoscopes, there's typically the 0-degree endoscope, which gives you a direct view, whatever's in front of the endoscope. There's 30-degree, 45-degree, 120-degree. There's variable angled endoscopes. Most commonly is the 30-degree, which gives you a view that's 30 degrees behind the endoscope, so to speak. And then also the advent of flexible neuroendoscopy has been a game changer, especially in the field of pediatrics, where we can drive the endoscope into variable configurations and locations through a single access port. Whereas previously, using rigid endoscopy, if you wanted to do, say, a biopsy of a tumor and a third ventriculostomy, you typically had to do two different approaches along the head to achieve those trajectories. Whereas with rigid endoscopy, I can do all of that work through one burr hole in the frontal region. Now, as we'll discuss in a bit, we're limited by several things when it comes to flexible endoscopy, such as resolution, working channels, size of the instruments I can insert in a flexible endoscope. So rigid endoscopy still plays quite a big role in endoscopic neurosurgery, but for the majority of what we do in pediatrics, we use the flexible endoscope. So when it comes to endoscopic neurosurgery, we typically break it down into three different categories. The first is what most people just call endoscopic neurosurgery, which is typically ventricular endoscopy, which involves working through the endoscope with endoscopic instruments in the ventricular system. And this is by far the most common. You'll see this the most on your rotations, and especially in pediatrics when it comes to dealing with hydrocephalus. And we'll talk about that as well in later on in the presentation. The next is called endoscopic controlled neurosurgery. And this is typically endonasal endoscopic skull-based surgery, such as pituitary surgery through the nose, or even endoscopic transcranial surgery, usually through the nose. And this involves working sort of beside the endoscope with instruments, meaning that the endoscope is your primary visual tool for doing the surgery. And then there's endoscope-assisted microsurgery. And this is where you use the endoscope and the microscope in the same operation. So the microscope typically is the primary visual tool of the surgery, but I can bring in the endoscope and use it as a tool to help me look around corners or in different areas that the microscope can't see. So these are important, excuse me, these are important when you discuss the type of surgery you'll be doing. And, when you say it's a endoscope controlled versus endoscope assisted, what we're talking about, what types of surgeries are going to be performed. So what are some limitations of endoscopy? The common indications of neuroendoscopy are typically treatment of hydrocephalus, cyst fenestrations, and biopsy, or even resection of small tumors within the ventricles. Those are by far the most common indications of endoscopy, especially in pediatrics. And in my practice and a lot of my partners and people in pediatrics, you can manage just about the whole spectrum of hydrocephalus with endoscopy. And it can be endoscopy as a form of treatment of hydrocephalus alone, or we even use endoscopy when we place shunts or we revise shunts. So, we use the endoscope all the time. You'll see it very commonly on a pediatric neurosurgery rotation. And not just ETV, but septostomies, foraminoplasties at the foramen of Monroe, aqueductoplasties at the cerebral aqueduct, or as I said before, placing a ventricular catheter or even removing a ventricular catheter that may be stuck in place due to scar tissue. And then I'll just briefly mention endoscopy used for resection of tumors or craniosynostosis or even vascular lesions. So because hydrocephalus is the most common thing you'll see in pediatric neurosurgery, I thought we'd spend a little time on endoscopy for hydrocephalus. And so I'm not sure where most of the students are in their neuroanatomy courses, but the anatomy of the ventricles can be broken down into the lateral ventricles, which are the frontal horn here in the frontal lobes, the temporal horn in the temporal lobes, and the occipital horn in the occipital lobe. This is called the atrium of the ventricles. This area here that I'm circling, it's sort of like a pathway that can get you into all of the ventricular horns of the lateral system from one point. The third ventricle is a single ventricle in the center that's connected to the lateral ventricles by the foramen of Monro, which if you talk about foraminoplasty, that's usually what we mean by the foramen of Monro. There's a foramen of Monro on either side that connects the right and the left lateral ventricles to the third ventricle. And then the cerebral aqueduct connects the third ventricle to the fourth ventricle in the cerebellum. So in pediatrics, we commonly see hydrocephalus as a result of blockage of flow at the cerebral aqueduct or even at the foramen of Monro. And the most classic indication for endoscopic third ventriculostomy is stenosis of the cerebral aqueduct, where we make a hole in the bottom of the third ventricle to bypass this stenotic area and relieve hydrocephalus without a shunt. You can see in these other diagrams, there's choroid plexus that lines the ventricles on both sides in the lateral system. And there's various venous structures that live around the outside of the ventricles as well that are used as landmarks typically. Usually once we have an endoscope in the ventricle, the maneuverability and the sort of driving of the endoscope is based on anatomy. So you might use image navigation to get you in the ventricles, but once you're in the ventricle, you really need to know your anatomy to know where you're at and what you're looking at and the surgery you're about to perform. So common questions for medical students and residents when I have an endoscope in the ventricle is, what am I looking at and where am I? And you should be able to tell me the venous structures, the foramen, certain white matter structures that you'll see, and be able to tell me where we're at. So as I mentioned, the most common indication for endoscopy in pediatrics is ETV, or endoscopic third ventriculostomy. Most commonly, we access the ventricles through a frontal burr hole, as if you're putting in an EVD or a external ventriculostomy drain. Some people like to use what's called a peel-away sheath, which you see here on the right side of the screen. And basically what that is it's a bit of a placeholder, if you will, that goes through the brain into the ventricle, and it allows us to have a channel that's always available. So if I were to withdraw the endoscope out of the ventricle, I can get back in very easily through this peel-away sheath, which gives me constant access. Now, sometimes I don't use a peel-away sheath, and I just literally put the endoscope into the ventricle, through the brain itself. Now, the disadvantage of this is if I have to pull out that endoscope, I got to get it back in there, and it's not super easy. So if I'm not using a peel-away sheath, I typically want to do the job I have to do in the ventricles and then pull it out and be done. I don't want to have to remove the endoscope and put it back in. So there's a couple different indications for that. And as I said, some surgeons always use a peel-away sheath, and that's fine. Some surgeons only use it in certain scenarios. The reason we call it a peel-away sheath is at the end of the case, we can kind of peel it out and remove it. And you can leave a Ommaya reservoir in place, which is a catheter that allows tapping in a chamber, for example. I typically don't leave an Ommaya reservoir after a standard ETV if everything goes well. Some surgeons leave it after every ETV. You'll see that variability in your rotations and the different surgeons you may end up working with. So here are some endoscopic still photos of the approach to a run-of-the-mill ETV. And we'll start on the left. On the left side, this is what it looks like when you're in the ventricle. When you enter the ventricle with the endoscope, this is what you want to look for. And this is the foramen of Monro. And if you look at this this image, you should always be able to tell the surgeon where you are and which side you're on, okay? So by this, I mean, you'll see the foramen of Monro here. The fornix, this is the fornix going around the foramen of Monro. This is a very important structure that I don't want to damage because this is very important in forming memories. And you can kind of manipulate the fornix a bit, but if you really hurt the fornix, that could be a problem for a patient. You can hurt their short-term memory. I also always look for the choroid plexus. Usually the choroid plexus will show me where the foramen of Monro is. So if I don't know where I'm at, or I'm a little lost, or the anatomy is unusual, I can usually find the choroid plexus with the endoscope and follow it to the foramen of Monro. And in this configuration, I know that this is the septal vein, which is on the septum pellucidum. And I know that this over here, this other structure is the thalamostriate vein. And so I know I'm on the right ventricle here, right? So if you're a medical student or a resident on a rotation, very common question, you know, but if the surgeon has the endoscope in place, they're going to ask you, which side am I on? And they're going to say, what vein is this? And you're going to say it's the septal vein, because that's easy. And then they'll ask what this white structure is at the upper border or the superior border of the foramen of Monro, and that's the fornix. So through the foramen of Monro, you can already see the bottom of the floor of the third ventricle. And I can see these structures here, which are called the mammillary bodies. So we then drive the endoscope through the foramen of Monro, and here on the second image, we visualize the floor of the third ventricle. And then you see these mammillary bodies here. This is the floor of the third ventricle that is our target for the ETV. And you can see it's already thinned out. If I can see through it, it's thin, and that's a good thing for an ETV. It also means that the patient has hydrocephalus, because that pressure will typically thin out that layer at the bottom of the third ventricle. And then the image on the far right is, this is a Fogarty balloon catheter. And so a lot of surgeons like to actually poke the hole in the bottom of the third ventricle with the Fogarty balloon. And as you'll see here, we push this little blunt instrument through the bottom of the third ventricle. And then in the second image, you see the inflation of the balloon. Usually it's with saline with a little syringe attached to it. And what that does is it dilates the hole. And then on the far right, you see the hole in the floor of the third ventricle at the end of the ETV, so to speak. The pituitary gland and the pituitary stalk are in front of you here. So you don't want to make your hole too far anterior, because you could hurt the pituitary stalk. This is called the infundibular recess, is another anatomical name for this area. So you want to stay away from here. And you also don't want to get too close to the mammillary bodies, because typically right in front of the mammillary bodies in the prepontine cistern, this is the cistern you're getting into, is the basilar artery. And if you hurt that artery, it can be really bad. So that's why typically in this area, you want to use a blunt instrument to make the hole. You don't want to use anything sharp. And you also don't want to use cautery, which is like if you were using like a Bovie or bipolar, because you have very, very important vascular structures just on the other side of the floor of the third ventricle here. So this is an example of a scan of a patient before and after an ETV. And on the left side, you can see the ventricles are large. There's transependymal flow in the brain, which means that CSF is under high pressure and it's starting to migrate into the parenchyma of the brain. But then after the ETV, you can see that the ventricles are now a normal size. The temporal horns here on the pre-ETV scan are enlarged. They've come down nicely on the post-op scan. And then this is the pre-op and post-op sagittal view. And you can see before the ETV, the ventricle itself, this is a mid-sagittal view. The lateral ventricle is enlarged and the third ventricle is enlarged. The floor of the third ventricle here is kind of bowed downward. And that's a sign that, you know, we had a communicating hydrocephalus above the tentorium. But look at the fourth ventricle. The fourth ventricle here is normal size. So this is hydrocephalus related to aqueductal stenosis, the #1 indication for ETV. So after surgery on the right side, you can see that the lateral ventricle is smaller. Also, the third ventricle is smaller. And you can even see here at the bottom of the third ventricle, you can see the stoma or the hole that was made during the ETV. So this is a successful example of an ETV in a patient. And this is exactly what you want to see on a post-op scan. So this is an example of a kind of a complex hydrocephalus situation that we dealt with a patient here at Lurie in Chicago. And this patient has acquired hydrocephalus from a large fourth ventricular cyst. And so you can see here in the mid-sagittal view, there's a very large cyst in the fourth ventricle that's blocking the flow of CSF through the aqueduct and down into the spinal canal. So you can see here on the axial view, same kind of thing. The ventricles are enlarged. You have transepidermal flow. And then here's a picture of that kind of complicated arachnoid cyst in the fourth ventricle. So this is a video of how we treated this patient with flexible endoscopy. So this is a very important point. So you can see there's the foramen of Monroe. So we're driving through the foramen of Monroe down and visualizing the floor of the third ventricle. Now we want to also open up the cyst in the fourth ventricle. So we're going to actually take our endoscope and we're going to flex it posteriorly. And that's what you're seeing here. See, I'm looking backwards with the endoscope towards the posterior third ventricle. And there's the cerebral aqueduct. And then now we can see this gigantic cyst that's living in the fourth ventricle. So the first thing we're going to do is fenestrate this cyst. And so we put this blunt probe in, and you can see we kind of popped the balloon and opened up that big cyst. So now we're going to take our flexible endoscope from a single burr hole, and we're going to drive it into this gigantic cyst. So now we're inside that fourth ventricular cyst, and we're kind of got to look around. And again, I don't have image navigation now, so I got to look and see landmarks so I know where I'm at. So you can see the dura, you can see the brain stem, the vertebral artery, and I can see pulsations at the spinal cord. So now I'm driving the flexible endoscope down to this is the foramen magnum, and you can see the spinal cord, and that's the ring of C1. And now we're trying to poke a hole in the cyst at the bottom to try to let the CSF get into the spinal subarachnoid space. We weren't able to do that, so we had to take a little bit of cautery and very carefully cauterize the bottom portion of that cyst. We then put in a flexible Fogarty balloon. You can see how we've opened up that balloon and we're trying to make the hole bigger. And so now we're driving the endoscope into the spinal canal. Next to the spinal cord, there you see some rootlets of the spinal cord. And you can see the spinal cord pulsating with the pulse from the heart and blood flow. You cannot do this with a rigid endoscope. This is only done with a flexible scope because you can't get a rigid scope that's much larger into these spaces. And so you can see the beautiful vasculature of the spinal cord and the bottom of that's C1 again, you can see at the skull base. So now we've fenestrated the cyst in 2 different places. And the idea is over time, hopefully this cyst will shrink away and the flow is established now from the ventricles. You can see the cyst is already shrinking away. So now we're back in the third ventricle and we're looking at the floor of the third ventricle. You can see it pulsating there. So now we're going to do an endoscopic third ventriculostomy to kind of add additional CSF flow just in case our cyst fenestration doesn't work. So you can see here, we're making the hole in the floor of the third ventricle. And we're driving the endoscope now adjacent to the basilar artery. So that's the basilar artery you're seeing. And we're very deep in the prepontine cistern. You can see the basilar artery perforators to the side. And the idea here is I want to see the spinal cord on the other side of the basilar artery if I can. If I can get down that deep, then I know that I've established CSF flow both posteriorly through the fourth ventricle and then anteriorly through the third ventricle and down in the prepontine cistern. And you can see here, I've made multiple holes. This is the membrane of Lilliquist. That's another question that attendings may ask you, like, what's this membrane? That's called the membrane of Lilliquist. Most anatomists believe that there are both vertical and horizontal portions of the membrane of Lilliquist, and I like to puncture both of those. So I'm very sure that there's CSF flow established all the way down into the spinal subarachnoid space. Because again, that's my goal, is to connect the ventricular subarachnoid space to the spinal subarachnoid space. Okay, so that's a complex ETV and cyst fenestration using a flexible endoscope through a single burr hole. So from a frontal burr hole, I was able to look down into the spinal canal, both posteriorly and anteriorly, using a flexible scope. That's why we love it so much. I can do a lot with it. Now, the optics of that flexible scope are not as good as a larger rigid scope, and I can't get a lot of fancy instruments through that small flexible scope, but I can do a lot with it, as you can see. The next thing I wanted to discuss, which is a common thing you will be asked on rotations, is something called the ETV Success Score. This was developed in Toronto based on a large group of patients and children, and they were able to predict with pretty good accuracy if an ETV is going to work in the setting of hydrocephalus. And so you may be asked, if you're seeing a patient on a rotation and they have hydrocephalus, the attending may ask you, okay, hey, what's the chance of an ETV being successful on this patient? And so here you can actually calculate the chance of ETV success at 6 months based on this table. And so what this does is it assigns a score, and that equals the percent of success. So for example, let's say I have a 6-month-old child with aqueductal stenosis. So I know based on age that at 6 months, that gives you 30. I get another 30 because the child has aqueductal stenosis, that equals 60. And then let's say this child has no previous shunt. So at this point, I know that I get 10 for that, I get 30 for a 6-month-old, and I get 30 for aqueductal stenosis. So I know that if I do an ETV in this child at 6 months of age, that there's a 70% chance that it's going to work. And this is actually pretty accurate numbers when it comes to chance of success. You can see, if you just look at the way this table is constructed, that the chance of success increases with increasing age. So that's why in small babies, especially less than a month old, their brains are just not ready or developmentally mature enough to be able to absorb the amount of CSF that's going to be created in the spinal subarachnoid space and even in the cortex at such a young age. And so that's why ETVs are more successful in older kids. Now, for me, that still doesn't necessarily stop me from trying an ETV in a baby if I can keep them from needing a shunt. And even if it's, say, it's only a 30 or 40% chance that they might not need a shunt, you know, for most pediatric neurosurgeons, and if you get into neurosurgery, you'll realize a shunt is usually a lifelong sentence. And I say sentence because this is one of those things where, you know, every time a person comes to an emergency room with a shunt, they're probably going to get a scan. Neurosurgery is going to get called. They're going to wonder, is this related to their VP shunt? You know, if I can spare any patient a shunt, then I will do my very best to prevent that. Let's see. There's a question I'll address in the chat. And the question was, is endoscopic surgery a mainstay of neurosurgery residency, or does it require fellowship to perform? Nowadays, most training programs will teach you basic endoscopy, meaning ETV, maybe like transnasal endoscopy is becoming more common. You'll learn some basics, but I think if you want to say, I am a endoscopic skull-based surgeon, you're going to need to go do a fellowship. If you want to do, say, complex flexible endoscopy, like I just showed you in kids, obviously you have to do a PEDS fellowship and you need to learn that in pediatrics. But I would expect most adult neurosurgeons to at least know how to do a standard ETV in an adult patient. That does not require special training. You should learn that in your residency. Let's see. Another question. Let's see. How is the ETV score affected if the patient had fetal surgery for spina bifida? That's a great question. At the moment, we really don't know, but if you look at the ETV success score, it will include myelomeningocele in this center portion. And so at present, I would just say treat it as a myelo normally would. Now, that's controversial as well because we know that babies who are treated fetoscopically or for open fetal repair actually have a much lower incidence of PRE2 malformation. And so their brainstem and their skull base is actually much more favorable for an ETV. So if I have a child who's had a fetoscopic myelomeningocele repair, I would 100% try an ETV on them. I would also try an ETV on a regular myelo kid. So I don't necessarily discriminate. There are very few patients I won't try an ETV on. Mostly it's the post-infectious. If I have a kid who had a bad meningitis and has hydrocephalus as a result, those, as you can see on the ETV success score, those post-infectious hydrocephalus cases are really not going to work very well. And that's because the infection affects the brain at the most distal portion of the CSF pathway. And that's at the arachnoid villi and at the brain surface where the CSF re-enters the vascular system. And if that's scarred down and if that is not functional, no amount of endoscopy is going to make the brain reabsorb CSF, and those kids get a shunt. That's just usually the way that works. Okay, let's move on here. So that's essentially endoscopy for hydrocephalus in a nutshell. Now I wanted to talk briefly about endoscope-assisted neurosurgery because I do a decent amount of this in my tumor practice as well. And this is a technique where I use the endoscope and the microscope, primarily the microscope, but I bring the endoscope in to look around corners or to get to areas that I can't see very well as a tool. And it allows me to make much smaller craniotomies and much more minimally invasive approaches for brain tumor resections in adults, but also, for me in kids, but you can use this in adults very commonly as well. And here's an example of taking out a butterfly glioma or a glioma that crosses the midline through a single small incision. And you can see that, for example, in the top portion, we'd make our craniotomy above the tumor on the right side, and then you would resect that tumor with the microscope. But I can't look across to the other side very easily with the microscope. And that's where bringing this endoscope in and looking up on the other side, I can actually resect that tumor on the other side of the brain using the endoscope. And that's what we mean by endoscope assisted, is that I still need the microscope and I love the microscope, but if I can bring in the rigid endoscope and look up on the other side, I can do additional surgery that I wouldn't be able to do with the microscope. And so the most common application of this is the eyebrow mini-pterional craniotomy. Now, this is an adult patient. This is obviously not a kid, but this is a pterional approach that uses a small, minimally invasive incision and craniotomy just above the eyebrow. This is the positioning and the incision for this craniotomy. You can see here, we use one burr hole, and we typically make our craniotomy above the eyebrow. The incision here is actually within the eyebrow, and that's on purpose because I can hide that incision in the eyebrow line very nicely. And the cosmetic result of this is quite good. And it saves getting the traditional pterional-like incision way back here in the hairline, this big long incision. So this is a great approach. I use this a lot in pathology and the anterior skull base. And so what I mean by that is here. So you can see this is my craniotomy in the kind of the black shaded area. And I can view multiple planes all the way across to the other side of this anterior skull base with some of it with a microscope, but I really need the endoscope also to, if I want to look over here on the opposite side of the patient or back here at the area of the carotid, I really need that endoscope. The microscope is great over here near my craniotomy, or even back here to say the ipsilateral sphenoid wing. But if I want to look way over top, or if I want to look below the sphenoid wing, I really need that endoscope. Here's another example of what I was mentioning. And that shaded area shows everywhere I can see if I'm using this craniotomy. And again, these are sort of the limits of where I can look. But if I bring an endoscope in, I can actually look even back below the sphenoid wing. I can look in the sella, in the pituitary gland. I can look around the carotid arteries. I can look behind the optic chiasm. So the endoscope here is a great tool to help me look inside and get a deeper view that I can't see with the microscope. And so this is the way we set up the operating room for this type of case. You can see that I have, we're at the head of the patient, and I have the microscope to one side, but I also have the endoscopic unit or the visualizing screen above the patient here. So I can use both the endoscope and microscope throughout this case. You can see here's the anesthesiologist taking a nap while I'm doing the case. And so these are just very quickly the steps of the procedure, going from opening the eyebrow, making a single burr hole in the keyhole area like you would with any normal sort of pterional craniotomy, and then doing a small craniotomy just above the eyebrow in that area, and just superior to the orbital rim. I keep the orbital rim intact. I don't want to damage that, but I can look down the orbital rim, and I even drill it away a little bit. You can see here I have to drill away a bit of the orbital rim to see down along the anterior skull base. And then we open the dura towards the eye, and then I can see the underside of the frontal lobes and work below them. Here's some intraoperative pictures basically showing the same thing. This is the periosteum that's reflected inferiorly, and I can see the area of the keyhole, the pterion, where I want to make my burr hole. And then I have the area of my craniotomy sort of prepped and ready to go for the drilling. This is just showing that I want to make sure when I make my craniotomy that I make it big enough that I can get my bipolar in there, because I got to be able to work bimanually inside this craniotomy. The craniotomy itself is quite small, and you can see here's what it looks like immediately after we do the craniotomy. But you can see there's still a bit of bone left here along the anterior skull base that I need to make go away so I can see down below. And by drilling some more, you can see how I drill away the rim of the orbit. And now I can see that's the orbital roof right there. I can see down orbital roof and all the way down the anterior skull base to the opticocarotid triangle. And by opticocarotid triangle, I mean this. You'll see that the working corridor is like a pyramid here. And I can work between the optic nerves. There's the pituitary stalk and the pituitary behind the optic chiasm. I can see the ACA arteries here. I can see the ACOM, the anterior communicating artery here. But from angles, I can also work back here to the MCA artery, to the PCOM artery here. You can even get back sometimes as far as the P1 segment of the posterior cerebral artery. But this pyramid is sort of a visual representation of the angles that I need to be able to work. And that's where the endoscope becomes a great tool for these type of approaches. So this is after we've opened the dura. I've reflected the frontal lobes downward, and I'm looking at the optic nerve right here. So this is the optic nerve. This is the anterior skull base at the top of the screen. You can see the carotid artery just behind the optic nerve here. And then there's a tumor here that's just behind the optic nerve that I'm going to try to remove. And you can see this is through the microscope. So this is the view I'm looking at with the microscope. So I'm looking at the tumor. I'm starting to take the tumor out and work it away from the carotid and from the optic nerve, which you see here on the side. And this is another view of the carotid artery and the optic nerve through the microscope. This is the frontal lobe of the brain that we've kind of moved downward so we can see to those triangles that I was showing you. Now, we always have the endoscope ready to go, and we can put the endoscope in to look deeper and further around that area to view the triangles in that anterior skull base that I want to see. And so this is an example of what I can see with an endoscope. I can see much wider view than I could with the microscope. And I can see the temporal lobe here. I can see the frontal lobes. I can see, the pituitary gland. You can see the ipsilateral, or ipsilateral will be here. Sorry, the ipsilateral carotid, ACA, MCA. But I can even see to the other side and see the contralateral carotid, MCA, ACA. All of these branches I can see even back into the anterior third ventricle. So the endoscope in these cases is a great tool. Now, the hard part about using the endoscope in these approaches is that I typically lose the ability of bimanual dissection, meaning that when I have the microscope in place, I can use both hands to resect a tumor or to clip an aneurysm or do the surgery. When I have an endoscope in, it's hard to have two hands down inside working. So usually you have one hand working the endoscope and you have one hand working an instrument of some kind, whether it's a suction or a bipolar or a dissector. So, I would be hesitant to do a full surgery like this with just an endoscope, although some people do surgeries like this without a microscope. So that is an example of an endoscope assisted. Now, I'll very briefly mention endoscope controlled surgery because we don't do this as much in pediatrics. We do some of it, but this is more of an adult based kind of technique where tumors of the anterior skull base and especially the pituitary gland can be addressed transnasally using the endoscope as the primary visualization method. Nowadays, in modern neurosurgery, just about everybody uses an endoscope for pituitary tumors. Not everybody, but just about everybody, because there's a variety of advantages to doing so. And so here are just some still images of a pituitary surgery for say it's a macroadenoma. And you can see here, we typically open the dura around the pituitary in an H shape or an X shape to get to the pituitary. And the endoscope allows us to get right up against the dura overlying the pituitary gland and the sella, enabling us to open the dura and also to this. As you can see, we have a dissector in here kind of working around the outside of the pituitary tumor to tease it away from the cavernous sinus and the pituitary gland in order to take it out. And you can see here that I can see the suprasellar subarachnoid space here. And you can see the sella, that's actually the upper portion of the diaphragm is the upper portion of the sella, sort of the dura above the sella turcica. And so this view is invaluable when doing pituitary surgery because I can see inside the cavernous sinuses, I can see up above the pituitary gland at the diaphragm, whereas with the microscope, you're really kind of limited to what I can see and do. And we can even work with two instruments through the nostrils through an endoscopic approach for these cases. Again, I think you'll see this primarily on your adult neurosurgery rotations for pituitary tumors or adult skull base tumors, but We do some of this in pediatrics. Obviously, much more common for an intraventricular application than it is for this sort of application for like pituitary lesions. I see we have, let's see, another couple questions. Okay, so is this type of surgery performed by ENT surgeons? So for these kind of cases in the at the sella, at the skull base, is a team, and so usually I need an ENT surgeon who's trained for endoscopic skull base approaches to help me get there through the nose. And a lot of times they'll do, like if we go back a couple slides, you can see here, this is called, on this left figure, this is called a nasoseptal flap. And what that is, it's the mucosa of the nasal septum that's dissected away by an ENT surgeon. And what that does is at the end of the case, you can take that piece of mucosa that's still attached to the remainder of the nasal mucosa, and you can rotate it up into the pituitary area, the sella, and the sphenoid sinus, and it can be a nice barrier to CSF or the additional neural structures. And so I need a ENT surgeon to do that. They are much more comfortable working in the nose and harvesting that mucosa in order to do that. And so these are almost always a team approach where the endoscopic ENT surgeon is helping me get down there, and then we come in from a neurosurgical standpoint and open the dura and take the tumor out, deal with CSF leaks, etc. And then typically the ENT surgeon will pack the sphenoid sinus at the end of the case and sort of make it as watertight as possible when it comes to CSF. I don't see any other questions at the moment. And I think that's all I had. I know we're right at the hour. So thanks for the opportunity to talk to you guys. I'll be happy to answer any questions if you have them. My email is here. If you guys have interests that I can help you out with or questions to answer. So thanks very much.
Thanks so much, Dr. Decipher. That was really cool, and something that we haven't done that much at the training center in terms of lecture zones. So we really appreciate it. I don't see any other questions. Oh, okay. Here's one just popping up in the Q&A box.
So is there utility for ETV in normal pressure hydrocephalus? So in general, no. Because I guess the hypothesis behind NPH or normal pressure hydrocephalus is similar to like an infectious point where the brain itself is not able to reabsorb CSF. And so, in general, the normal CSF physiology, the average person is making about 20 cc's an hour of CSF. And so that means to stay in a homeostatic point, you have to be able to reabsorb that same amount, or you're going to get hydrocephalus. So what most people believe in NPH is that there's an imbalance in the reabsorption phase. And so in similar fashion, I think if you're not able to reabsorb spinal fluid properly, no amount of endoscopy is going to fix that. And so that's where the shunt has to be used. And obviously the shunt is taking the CSF out of the brain into a different site, whether it's the peritoneum or the heart or the lung or gallbladder in very rare cases. But in those scenarios, endoscopy is not going to help you.
All right. Well, thank you so much again for that lecture and for making your email available. We really appreciate it.
Yeah, my pleasure, guys. Good luck to all the students. Hopefully those are the, if you're on a rotation, those are the questions you should know. You'll look like a star if you're attending asks and you know these, and especially if the resident doesn't, that'd be awesome to show up the resident, because a lot of times, you'll be able to answer some these like pearls and make the junior resident look kind of silly. So anyway, good luck, guys. I'll available by email if you need me. Okay.
Thank you.
All right, guys, take care.
All right, folks, we're going to transition to our final talk of the day. Thanks, everybody, for sticking in there. I know it's a really long day here. Let's see. Not seeing the faculty yet, so maybe take a couple minutes to stretch your legs, grab some coffee, whatever you need.
Hi, Dr. Mufti. I think you're maybe signed in through my account, so you can just change your name.
Oh, sorry about that.
It's okay.
How do I change my name?
I might be able to actually do it. Hold on a
Yeah, if
second.
you could do that, that'd be great. Yeah.
Maybe I can't do it. I don't know. Michael, do you know? I had to send him this one because I couldn't find the other link.
Oh, yeah. Let me see. All right. Now, let me see which one is which. Rename.
Mike, long time no see.
There you go.
Yeah, how's it going, Dr. Mufti?
I can't complain. Can't complain. Things are good. How's Dr. Gupta?
Keeping me busy as usual.
I'm sure. Oh, of course he is.
It's all good stuff.
I would imagine nothing less.
Can't complain.
Excellent. I apologize for the delay. I've been trying, like I searched everywhere for this link. I could not find it for some reason.
No, we've just been having some problems with the training center sending the links. I don't really know why it doesn't work. We need to circumvent those issues in the future. But thank you for coming.
Yeah, that's weird.
Oh, it's my pleasure. Thank you all for having me.
Absolutely. So I think you should be able to share your screen and do video and everything. So you should have full controls now.
And then while you're doing that, I can go ahead and introduce you. Okay, so thank you everyone for hanging in there while we were troubleshooting some of these issues. But Dr. Mufti is one of the few triple trained neurologists, neurointensivists, and neuroendovascular surgeons in the country. His research expertise is primarily in subarachnoid hemorrhage and acute ischemic stroke. He strives to synergize his clinical training and research interests to gain an in-depth understanding of devastating neurological diseases and to improve patient outcomes by applying early identification of novel treatment targets while enabling innovations in precision medicine. So that's why he's here today, to give us a great talk on the nuts and bolts of endovascular surgery. So thank you again.
Of course. No, thank you guys so much for having me. If you'll just allow me, please let me know if you can see my screens.
Yep, we can see it.
All right, excellent. So today we're going to talk, so thank you so much for having me join today. It's truly a pleasure to speak to you all. So the goal of this talk is basically just to give like an introduction on neuroendovascular surgery and where the field is now, where we anticipate it going. And maybe I always like to start my talks by giving a little bit about the history of the field and how this all started. So neuroendovascular surgery, typically, like this field was founded on multiple, if I'm going to be honest, initially futile attempts to help some of the sickest patients, the most helpless patients. With constant perseverance, we were able to, despite multiple failures, and like the initial efforts were obviously labor intensive, but there was some hope. Determination, innovation led to tremendous improvement in what we can actually offer our patients today. Does anyone know who this person is? So this is Igaz Muniz. He's actually like a Portuguese neurologist who developed cerebral angiography. He was the very first physician to be able to visualize the vessels inside the brain. If you think about this, like how hard is that? Like how do you, like what we take for granted today, just imagine how difficult it must be to create initially contrast. And then they had X-rays, and then he had to think of like a way to inject something that is radio opaque. And at that point, they knew that the only thing that was radio opaque was metal. So how do you inject metal, like something metallic, something that's radiopaque, into a blood vessel without killing the patient? Now, needless to say, a lot of patients died in the process. But he was able to perform his first cerebral angiography in Lisbon in 1927. His main goal was not actually to identify, like many things we've discovered in medicine, his initial goal was not to visualize the vessels, but basically to visualize tumors in patients. So this was a 53-year-old man with history of seizures and hemiparesis. And the suspicion was this patient might have actually a tumor. So the cervical internal carotid artery was used for access. Again, his initial attempt was to, goal was essentially to visualize brain tumors. And the novel idea was essentially to use images of blood vessels by injecting opaque substances. Dr. Moniz named this procedure like encephalography arterielle. On June 28, 1927, he was able to visualize to achieve visualization of a pituitary tumor in a young man. The first cerebral venogram was established in 1931, several years later, when there was inadvertent delay in photography of, in photographing basically as they put in the angiographic plate to take the picture, it was too late. It was already in the venous phase. So they're like, oh, well, this looks different. This must be the vein. He was actually awarded the Nobel Prize in Physiology and Medicine in 1949 for his work on frontal leucotomy for psychiatric disorders. You can see this is this is now decommissioned Portuguese currency that actually has a picture of Dr. Moniz and a cerebral angiogram on their currency. They're very proud of him, as they should be. The transition from a direct puncture to the cervical vessels to transfemoral arteriography began many decades later in the 1960s and became widespread in the 1970s. Unfortunately, Dr. Moniz became paraplegic at the age of 65 after being shot by one of his schizophrenic patients. And after the accident, you'd think the guy would retire. He didn't. He was confined to a wheelchair and still continued to practice until his death. Since his death, cerebral angiography remains at its core a powerful diagnostic tool with major advances in technology and devices significantly expanded its role to the front lines of treatment of cerebral aneurysms, or AVMs, dural AV fistulas, CC fistulas, carotid disease, large vessel occlusion strokes, and to this date, it remains the gold standard intervention as far as treatment of a visualization of the vessels in the brain. It's definitely humbling to think how far we've come in the past 92 years since its inception, and it's up to us, the future, the current generation of trainees, fellows, to continue to push the field forward. The very first neurointervention was actually conducted by Dr. Alfred Lusenhoff, and I'm sure you guys have heard of the Lusenhoff lecture at the in many of the larger neurosurgical meetings. Dr. Lusenhoff was born in Westfield, New Jersey, attended medical school and residency at Harvard, and joined the NIH and simultaneously clinical practice at Georgetown. At age 36, he became the chief of neurosurgery at Georgetown and remained serving in that capacity until 1993 when he retired. His first intervention was actually that of an embolization of an AVM. And the way they did this, they explored the concept using embolic material of various types to occlude arteriovenous malformation in the 1960s. These particles were introduced through an arterial cut down in the neck and direct surgical exposure rather than transfemoral or transradial approach. And you can see over here, basically what they did was they injected these a tiny thread into the blood vessel and hoped that it would actually engage into the AVM and cause some thrombosis. In the 1970s and 1980s, neurologists and neurosurgeons were actually excluded from obtaining training in therapeutic neuroendovascular procedures. However, the number of clinical neurologists and neurosurgeons interested in the potential that these techniques held, these numbers increased, and they decided to actually train as radiologists. So they actually, those were like trained neurosurgeons and neurologists, went back and did residency in radiology. And once they completed that, then they actually started training other neurologists and neurosurgeons. The first year 2000 was the first neurologist that completed formal training and fellowship training in neuroendovascular. This is basically the path to neuroendovascular surgery today. It's composed. You can like engage in this field through 3 different paths, either through neurosurgery. You do it's a 7-year residency with typically you do a 1-year infolded residency, like one year infolded year fellowship year, followed by 1 year neuroendovascular surgery fellowship after conclusion of the residency. You can do this through radiology, 5-year residency followed by a 1-year neuroradiology fellowship, and then a 2-year neuroendovascular surgery fellowship, or you can do it through neurology, a 4-year residency followed by a 2-year neurocritical care, or 1-year vascular neurology followed by a 2-year neuroendovascular surgery fellowship. So no matter how you like decide to engage in this field, it's going to be roughly 7 to 8 years, no matter how you how you divvy this up. It's a rapidly expanding field. I always like to joke and refer to us as a modern family, similar to the TV show. Everybody, like, although we all come from different backgrounds, everybody brings something very unique to the table. Together, this is actually an incredible field because this is one of the unique fields where people of different specialties actually came together and advanced the field that was essentially dying, unfortunately. Medicine is rapidly moving towards minimally invasive procedures. Neuroradiologists developed it first to enter. However, unfortunately, there has been a steady decline. Neurosurgeons and ultimately neurologists joined, and the number has been rising. The most rapid rise is from neurology at this point. This is how I feel like as I was explaining, like I think everybody brings something unique to the table. In many of these meetings, we always refer to ourselves as a dysfunctional family, but somehow we managed to make this work. When not procedure, the main difference is like what you do when you're not doing procedures. Neurosurgeons may perform general neurosurgical procedures. Neurologists will diagnose and manage strokes or neurocritical care patients. Neuroradiologists will interpret radiographic studies. I'll be honest, I'm not entirely sure that statement is completely accurate because there are many neurosurgeons who only do neuroendovascular. And in their free time, they will essentially either do research or do administrative stuff. Likewise, there are a lot of neurologists who only do endovascular and a lot of neuroradiologists who only do endovascular. And in their free time, there's so much you can do in your free time that doesn't necessarily have to be like doing general neurosurgery or reading or managing stroke patients or just reading doing diagnostic radiology. What we do at the one thing that unifies us as a field is that we all do endovascular treatment of acute ischemic stroke, cerebral aneurysms, intracerebral hemorrhage, and spinal pathologies. And we all treat everything is treated through the body's vascular network. This field has become more diverse and interesting disease processes that were typically at the purview of other specialties, such as idiopathic intracranial hypertension or subdural hematomas, are now managed by minimally invasive, or to some extent, managed by neuroendovascular surgeons. Just going to go over like a brief case of like a patient with acute ischemic stroke. As you guys can imagine, this is the technology that brought us to where we are today is actually incredible. Now, this is actually a 7 Tesla MRI, and it then merges with like an electron microscopy views of the brain. It's absolutely incredible to see the resolution that you're able to visualize today. Absolutely mind-blowing, if you ask me. This is like essentially tracing the flow of a red blood cell into the brain from the arteriolar, capillary, venules, and into the the sinuses of the brain and back to the heart. Every year, almost 800,000 people will experience like a new stroke. There are only 1,100 stroke-trained specialists in this country, and on average, every 40 seconds, someone in the United States has a stroke. On average, every 4 minutes, someone dies of a stroke. And by the end of this talk, 90 individuals would have had a stroke and 15 people would have died due to a stroke. So with this being Stroke Awareness Month, I think this is honestly a very humbling slide. Like every time I go over these numbers, like it truly is very humbling. And I always feel frustrated, like when we see these numbers. It's extremely important to notice to recognize the signs and symptoms of a stroke. Many in the audience may feel like this is pretty straightforward, and it is for many, but believe it or not, I can't tell you how many physicians I've actually had who had stroke-like symptoms and decided to, let me go to sleep and wake up the next morning. Hopefully my right-sided weakness will resolve by the next morning. And like, this is something we see over and over again. However, sometimes maybe a little bit more subtle. So it's important as the physicians, even if you end up not going into this field, it's important as physicians to be able to identify these deficits. So unilateral weakness, numbness, visual disturbances, vertigo, double vision, imbalance or incoordination. The be fast is extremely important. But some things are a little bit more difficult, like aphasia. A patient who's globally aphasic will not be speaking to you and may not be answering, and they could be easily missed, especially in a nursing home, or like if they're in like subacute rehab, where all of a sudden they're not really following instructions. And the concern is, well, are they having a UTI, or is there something else going on? Neglect, very difficult to discern, confusion, and behavioral abnormalities. Interestingly, this is the stroke emoji. I did not design or create this. I found this emoji, and some colleagues of mine, we decided to just name this the stroke emoji. And we actually posted this on social media a few years ago. And I was actually extremely happy at the time because I want to say like 3 months later, a teenager found her grandmother like having symptoms of a stroke. She actually called 911. And this grandmother actually came. I ended up doing a thrombectomy, and I was talking to her, and I always commend the family for acting quickly and bringing their loved ones in as soon as possible. And the grandmother was actually telling me, oh, it's actually my granddaughter who picked this up. And I was talking to the granddaughter. She was like, oh yeah, like a friend of mine just forwarded me this like emoji, and I looked at this and I just remembered the fast mnemonic, and I thought this was essentially what my grandmother was having. We're slowly moving to a field where like a lot of mnemonics, I always joke saying like we're not unlike the ancient Egyptians as far as like communication. We're all using hieroglyphics now. We're using these emojis to communicate. And there are so many emojis that you can essentially use for neurologic disorders, from Broca's aphasia to delirium to basilar thrombosis to migraines with auras. So I'm going to go over like a brief case. This is an octogenarian with acute onset of confusion, had a motor vehicle accident, was actually in the trauma bay for a few hours before one of the astute nurses picked up that the patient was the weakness the patient was having, the left-sided face, arm, and leg hemiparesis was not due to pain, but rather due to like neurologic deficits. So a code stroke was called. This is a code stroke. I'm sure many of you guys have seen, like attended a code stroke. And there's always someone asking the most inappropriate question in like during a code stroke. So what next? We got the blood pressure, the vitals, labs, EKG. We got the NIH stroke scale. And I want to like pause here for a second, because the NIH stroke scale, more than anything, is a communication tool. It allows us to communicate amongst ourselves and with our colleagues in stroke neurology, the neurology residents, the neurosurgery residents, the nurse practitioners, the emergency department, EMS. When I hear like the story and somebody tells me this is a patient who's got an NIH stroke scale of 14, I immediately know that we're dealing with a serious stroke. This is not a patient with like a low NIH stroke scale. So more than anything, as opposed to someone going through the entire NIH stroke scale, describing dysarthria, facial palsy, the gaze, movement in one arm and then the other arm, then the one leg and then the other leg, giving me a score helps me make a decision pretty quickly. What you see over here, so neuroimaging is largely like I always describe neuroimaging as the way you tackle neuroimaging is primarily through comparing one side to the other. So I immediately draw an imaginary line across the center and I compare one side to the other. You can see over here, there's a dense MCA sign that's not there on the other side. Every second, 32,000 neurons are lost. Every minute, almost 2 million neurons are lost. Almost 120 million neurons are lost, and the patient will age almost 3.6 years every hour that the brain goes without reperfusion. A typical stroke will cause a patient to lose 1.2 billion neurons, and it's not unusual for a patient in their 50s to walk out of the hospital, comes in with a stroke, to walk out of the hospital with the stamina and the frailty of an 80-year-old. Patient was more than 8 hours since last known normal. We took him directly for a thrombectomy, did not receive TPA. There was an ICA terminus occlusion, a tandem occlusion. We were able to open up the blood vessel. The ACA opened. There was an M1 occlusion next. We were able to open up that M1 through this technique. So this is an animation that demonstrates like how we're able to tackle like thrombectomy. So basically a guide catheter is positioned in the neck. A micro wire is essentially passed to traverse the clot, followed by my microcatheter. Then the microwire is removed and a stent retriever is introduced. And then you pin and unsheath the microcatheter so that the stent retriever engages into the clot. And as you're about to pull the clot, I inflate a balloon in the neck and I pull the stent retriever and retrieve the clot. There is essentially complete TQ3 recanalization within 25 minutes of groin puncture. This is the clot that we removed. This is the stent retriever that we used and a flow gate balloon guide catheter. At 24 hours post-recanalization, the patient had a remarkable recovery with a residual NIH stroke scale of 2. So that's one of the things that we do. I'm going to talk a little bit about like neuroendovascular management of aneurysmal subarachnoid hemorrhage. This is basically what we do. I'm going to try to silence this. So basically the way we treat aneurysms today is through endovascular means. You basically advance a guide, like a guide catheter over a intermediate over a microcatheter and insert into the aneurysm over a microwire, and you can coil the aneurysm. This is how an aneurysm develops and ultimately ruptures. And subarachnoid hemorrhage obviously is a devastating disease. This is a case where the aneurysm had a wide neck, so a balloon was inflated at the neck. This is obviously like 4 times the speed of our coiling. This is an example of flow diversion of an aneurysm, deploying a stent across the neck, diverting blood flow away from the aneurysm.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.